right. So welcome, everyone, today to today's ACLP Journal Club, Virtual Journal Club. Just a reminder, we're working our way through the ABPN article-based pathway for maintenance of certification for CL Psychiatry. So if you're interested in presenting for a future one, let us know and we can discuss it. For today's Journal Club, I'm very pleased to introduce Dr. Yelizaveta Sher. Dr. Sher is is well known to many of us in ACLP. She's Clinical Professor of Psychiatry and Deputy Chief of the Division of Medical Psychiatry at Stanford. Her clinical work includes attending on the critical care psychiatry and transplant psychiatry services, as well as being embedded in Stanford's adult cystic fibrosis clinic. She's passionate about disseminating knowledge on and further studying dyspnea and dyspnea-associated anxiety in her patients. Today, she will be discussing a 2024 article that she wrote entitled Dyspnea and Dyspnea-Associated Anxiety in the ICU Patient Population, a narrative review for CL psychiatrists. In terms of logistics, Dr. Sher will speak for about 20 minutes, and then we should have about 8 minutes of time for discussion. So if you have any questions, please use the Q&A feature on Zoom, and we'll try to get through as many questions as we can at the end of the presentation. Dr. Sher, please take it away.
Thank you so much. And I'm only able to see the slides, so let me know if there's anything else that needs to be done. I don't want to mess with the screen at this point. All right, well, thank you so much for the welcome, and I'm so excited that everybody hopefully is just as excited about dyspnea as I am, and everybody who has rotated and worked with me kind of definitely has been brainwashed about this topic, and hopefully this continues. And I want to thank, of course, my collaborators who have written this paper with me in 2023, and then it was published. Dr. John Soleil, he was a resident at that time and was a fellow with us last year. Now he's in the world practicing ICU psychiatry. And also we had Dr. Desai and Dr. D'Souza, who were the critical care fellows rotating with us at Stanford. And it was wonderful to have their input and collaboration on this article and work as well. So let's dive right in. So why talk about dyspnea? CL psychiatrists, right, especially ICU, right, critical care psychiatrists, we get consulted about dyspnea all the time, whether or not we realize it or the primary team realize it. Often the consults that come in for agitation, delirium, anxiety, right, or those consults for please help us wean off patients of the ventilatory support, right, the lungs are fine, but it's the anxiety that's preventing them, or the trach trials. Those are often, right, these are especially prime for us actually thinking about and screening for dyspnea. Often it is the primary consult question, even though it's not specified. And often it is a comorbidity in many other requests as well, right? Your delirious patient in ICU probably is also dyspneic. Dyspnea is common in ICU patients, and it is very distressing. It's actually the second most distressing, sort of like the neuropsychiatric symptom in ICU, second after, sleep. Being sleep deprived is also super distressing. When patients are not able to breathe, they feel they're not able to breathe, it feels that they are dying. So we can kind of see how very, scary that would be. And yet, surprisingly, it is not screened yet for. I mean, I do hope and I do think that with time that will change, right? We do screen for delirium, we screen for pain, we screen for many things in ICU. We do not screen for dyspnea. Of course, it's being treated there, but it's not actually explicitly necessarily acknowledged. By definition, it relies on self-report, and we'll talk a little bit more about it. But many patients in ICU are non-communicative. But the pathophysiology of it is very complex and not fully appreciated. And I think understanding more about it and talking more about it amongst ourselves and also with our colleagues can be actually very helpful. And we are involved in those consults very frequently. And I do think that we can actually help start talking about it more and help address it in a multidisciplinary way. This is not to say that we've resolved all dyspnea at Stanford ICUs yet, or that we have that every time we tell them to change vent settings, right, ICU attendants listen to us. But I think we do have those conversations much more frequently these days. So what is dyspnea? First of all, it's and this is important, self-reported subjective experience of breathing discomfort, right? It's a symptom that is told to us by our patients. And in a paper that I will definitely all recommend for you to read, that was published, shortly after this article by Dimula and colleagues who are amazing ICU, clinicians and researchers from Europe. So they actually described this, dyspnea as one of the symptoms of the respiratory-derived brain suffering, right? And it can be correlated with objective respiratory signs, right? If somebody is really bad, they will be hypoxic eventually. Right? The patients can have increased heart rate, respiratory rate, or blood pressure, but not necessarily. The patient tell us that they have difficulty breathing. By definition, they have dyspnea. But, right, at least 1/3 of the critical patients are not communicated. It might be that they're physically not able to communicate. They might be sedated. Does not mean that they're not experiencing dyspnea, or they might be delirious, right? So they might have difficulty actually interpreting, right, what is happening, right, in terms of their body sensations. So then it's even more difficult to, of course, ascertain the symptom and diagnose it. It does not mean that they do not suffer from it. Approximately 40 to 50%, right, the different ranges of patients, when the studies are done, do report dyspnea in ICU, right, and either by self-report or by other tools that we'll talk about. And patients in ICU with dyspnea are 9 times more likely to have anxiety. First of all, it's, pathophysiology is shared, right? The limbic system is involved in both. We'll talk about that a little bit more as well. But also, of course, when you're not able to breathe, like it makes sense that, you will feel panicky and scared existentially. So both existentially, but also pathophysiology-wise, it does make sense that these patients will be anxious, and that's going to feed into the loop, right? But dyspnea is often driving that, at least in the beginning. And, it is associated with delayed extubation, worse prognosis, and potential mortality. And after ICU, dyspnea is associated with PTSD in the survivors. And the density of dyspnea, right? How often patients have experienced dyspnea, how bad it was, is also associated with, the incidence and how bad PTSD is. So in addition to delirium, right, use of benzos in ICU, dyspnea is also a risk factor. Let's talk about the pathophysiology of dyspnea, right? And it's based on the pathophysiology of breathing, of the, brain-lung connections. And of course, this is complex. This is a very simplified way of thinking about it. And, again, thank you, Dr. Slay, for this beautiful presentation that you can enjoy in the article. So first of all, right, when we are asking patients, do you have difficulty breathing? After, we screen them for delirium, and then we ask them, do you have difficulty breathing? This is how we're certain. This is how we start actually screening for that. And then there are usually what I do, there are 3 flavors of dyspnea. Does the patient feel like they have to work harder to breathe? Do they feel like they have air hunger, right? There's not enough air, or do they feel chest tightness? And those different sensations that often are comorbid, right? They're kind of different manifestations of different pathophysiologies. So with the first one is the excessive work of breathing or ventilation drive, right? So our motor cortex sends signals to the intercostal muscles, neck muscles, and other accessory muscles. At the same time, the brainstem, the phrenic nerve, sends signal to the diaphragm, right, to breathe, right, in response to what is happening. And at the same time, there's actually a copy, what is called collary discharge, from motor cortex and brainstem to the sensory cortex. There's a copy that's being made, right? The brain remembers, this is what I'm telling the body to do. And then it compares with the input. And if there's a mismatch, right, if the lungs, if the body is not able to produce that, right, this produces the sensation of increased force of breathing, right? So if the brain is sending the signal, okay, I need to produce more volumes, right? But patient, let's say on a, is not able to do that. The lungs are not able to generate, bigger ventilatory volumes, right? There's going to be that mismatch, right? And patients are going to feel that. The second process is driven by the peripheral and central chemoreceptors. We have peripheral chemoreceptors in aortic arch and bulb, and they send signals to the brainstem. They're kind of responsive to PO2 and PCO2. And we have central chemoreceptors that are responsive to the hydrogen ions and also concentration of CO2 in medulla, and then it gives feedback to amygdala, right? So patients who are hypoxic, patients who are hypercapnic, they're going to have that air hunger, right? They're going to tell that to us. And of course, right, we see that the limbic system is not involved, and this is also what is responsible for some generation of anxiety, right? The fear, the panic. It's also kind of mediates the pain response as well. So we can see how these patients will feel anxious. And the third mechanism that mediates kind of chest tightness, right? We have stretch receptors throughout the lung parenchyma, chest wall, intercostal muscles. We also have a variety of the stretch receptors that are, different ones in the airways, both distal and proximal, right? And they're going to respond to any nauseous stimuli, right? If there's mucus plugging, right? If there's pneumothorax, if there's something else. And they're also going to kind of feed back, right, to the brainstem and then high up, right? And that's going to produce a sensation of chest tightness. So we can see how somebody who's maybe sort of optimally managed, right, but in ICU, they're still intubated, right? They wasted the muscles away, they're anemic, they have protective volume ventilation. They will tell us that they have difficulty breathing, even if their numbers look okay, right? So if we have this language to communicate, to understand ourselves and to communicate with other providers, I think it gives us the framework, right, to collaborate together and help our patients better. Based on this, right, so what are contributors to dyspnea? And again, right, I'm focusing often, on, I'm thinking about a particular unit in our hospital, and my colleagues know the unit, right? But a lot of these are our cardiothoracic patients, right? So often it is the intrinsic underlying disease that brought them there, right? And let's say patients are ventilated, and hopefully of course we're doing everything to actually help them with initial symptoms of dyspnea. But let's say somebody has been stable and now we are consulted for, let's say, worsening anxiety, right? We will think about, as CL psychiatrists, okay, what might be happening? Did they develop pneumothorax, pneumonia? Is there more telangiectasis, right? What else? Did they drop their blood counts, right? And now they're more anemic, right? So there's definitely those other factors, right? That are the intrinsic cardiopulmonary status and other factors that can contribute to worsening of chronic or now new acute dyspnea. There are neuromuscular factors in ICU, right? Our patients get deconditioned, right? The intercostal muscles are weakening, right? The diaphragm is getting weaker. Thinking about our lung transplant patients, right? Maybe not one of the diaphragms has been sort of injured, right, during the surgery. So this is going to make it difficult for them to have the satisfactory ventilation. Ventilatory settings, of course, again, right? The ventilation is there to help, right, to treat. But for example, lung protective ventilation, right, that is created to actually decrease mortality, right, to help against the barotrauma, volume trauma, but it produces low tidal volumes, permissive hypercapnia. We know based on pathophysiology that's going to lead to air hunger, right? Metabolic factors such as anemia and pain. Patient ventilatory interface, right? Sometimes we hear that I look at the patient, I'm not touching the patient and he looks fine. As soon as I walk into the room, they now tell me that they're anxious. Well, right, they have to do more, right? Then maybe when we turn the patient or the work with PT, or even when medications are being administered, that interface, right, triggers the brain to ask, like the lungs, the body to do more, right? So we can see how that actually can trigger that mismatch and dyspnea. So how do we identify dyspnea? This slide is, in the paper, of course, right? We first identify dyspnea by asking the patient, right? Do you have difficulty breathing, right? Are you struggling with, do you feel like you have to work harder, hard to breathe? Do you experience air hunger? Is there chest tightness after the screen of delirium? And if the patient is communicative. But there's also tools that can help us, right? Especially if patients are non-communicative. So first of all, if patients are able to have difficulty breathing, just asking them, just like we do with pain, using numerical rating scale or visual analog scale can actually be very helpful, right? Asking them to rate the difficulty of breathing from 0 to 10. And usually we think 4 and above is a significant number, something to think about. And we can, of course, also track it. But let's say patient is not able to communicate, right? Either because there's no way or they're delirious, right? There are tools that have been created and validated that we not use, but yet, but it can be helpful and you can definitely think about them. And again, this article by Dinuli that you can see, on the bottom, if you go to the article, they even have the link to the calculators, right? Because this is not like this is not a linear equation, but they do look at other symptoms and other correlates of the respiratory derived brain suffering, right? It is heart rate, respiratory rate, restlessness, paradoxical breathing, movement, like expressions of fear. And there are different tools for if patient is ventilated, right, and he does, or they're not ventilated yet, and then whether or not they actually have oxygen support. So based on the other signs, it's not ideal by definition, but it does seem to actually help us to further understand who does struggle from dyspnea in the hospital. How do we treat dyspnea, right? So after we identify that this is part of the equation, right, and we do that also by talking to nurses, by talking to ICU physicians, by talking to respiratory therapists who can be very helpful to help us understand what's happening. of course, often the initial treatment of dyspnea will be back on the team, right? And sometimes it is for us it doesn't mean that we're not going to treat dyspnea-associated anxiety, right? Which is frequently part of the picture, and which is terrifying and uncomfortable, and it can worsen, right, what is happening. But often we might provide additional suggestions to the team and work together, right? So the team will work on reducing non-respiratory stimuli, respiratory drive, right? The fever, maybe transfusing the patient. They will work on minimizing respiratory impedance and alterations of gas exchange, right? Obviously treating pneumonia, right? Or anything else that is happening. And they might optimize the ventilatory or ECMO settings. It's okay for us to suggest that and to question that, right? Hey, we've noticed, right, that when the settings are changed from ACDC to pressure support, right? And maybe that is an appropriate step because, they want to see the patient can tolerate that. That is an appropriate step in the treatment, but we know the patient is really distressed. Are they ready for that, right? Or when you drop their pressure from 15 to 10, right? The patient telling us that they're so afraid, they're very scared. It's very uncomfortable for them. They feel they're not getting enough air. Can we do this a bit slower? It's okay for us to suggest that and to work with the team, right? Or think about even the ECMO settings, right? Have you guys thought about, the changing the sweep, right? So maybe the ECMO machine does need to remove more carbon dioxide. It's okay for us to kind of ask those questions and to work together with the team. So let's say they are optimized, right? Ventilatory settings are optimized, or if the ECMO is optimized, they are treating pneumonia, right? They're transfusing them, and patient has been in ICU for a long time, right? They are deconditioned, the lungs are not in great shape, but now the step forward is for us to push them, right? To kind of like engage the muscles, right, of the lungs and to rehabilitate. And patients will feel dyspneic as they progress in their rehabilitation, right? So this is where we can kind of support, right? Educate the patient, validate the patient experience in front of the team, and treat their also dyspnea-associated anxiety, right? We can also use non-pharmacological, right? Kind of, they can be helpful. Positional changes, although of course the patient is intubated, it might not be possible. Firstly, breathing, that's also for non-intubated patients. Relaxation practices, right? Progressive muscle relaxation, with whatever muscles they have left, right? Music, and airflow fan, has been suggested. It might depend on the infection control in your hospital, different units, but kind of, but patients also clinically do report that, flowing some cold air might be helpful as it kind of it stimulates some of the nerve endings. So that might be helpful. And then pharmacologically, right? What do you think about pharmacologically? So pharmacologically, oxygen is helpful in hypoxemic patients, right? Not in normoxemic patients, right? So in hypoxemic patients, oxygen is helpful. And then the only other pharmacological indications to help with the sensations of dyspnea per se are opiates, right? Because they tune down, right, they depress the respiratory drive. They turn down the sensitivity of the brain to the input that they're getting, right? And they kind of help to correct this mismatch, right, by diluting the sensitivity. And in intubated patients who we need to rehab, it might be a safe measure. That's something that we might suggest to our, collaborators. Of course, if somebody is extubated, I can see how they might be worried about suppressing their respiration, right? But opiates is something that might be considered, and really the only pharmacological medication intervention that is helpful for dyspnea. Everything else that we suggest, which is helpful, is for dyspnea-associated anxiety, right? I also want to highlight what does not work, right? For example, propofol, which is used all the time, but it's a highly effective amnestic sedative, right? It kind of shuts up the hippocampus. Patients do not have memories necessarily, but it's actually relatively effective at suppressing activation of amygdala, right? Which is activated during dyspnea, pain, anxiety, panic. So when a patient is sedated, right, they might not have concrete explicit memory. They can have, they can definitely have sort of the imprint on their brain. Benzodiazepines not effective for dyspnea. They are effective for anxiety. So if somebody has anticipatory anxiety now, right, before weaning down their support or trach collar, we might use a little bit of benzodiazepine if the patient is not delirious, right, but not it's helpful for dyspnea per se. And then paralytic agents, right, that teams have to use, sometimes when patients really dysynchrony and they just have to paralyze all the muscles so they can take control, right? These patients really need to be sedated. Like paralytic agents obviously do not help with dyspnea per se. Again, this is a busy slide. This is a table in the paper. But again, going through the pharmacological agents, right? Everything else that I've listed, outside of the oxygen opiates, right? It's for the treatment of dyspnea-associated anxiety, right? Something that we can consider kind of short term, right? Let's say maybe even benzos, right? a little bit of alprazolam before changes in ventilatory status or trach column, and then everything else in the table, right? We can schedule them or use them PRN, alpha-2 agonists, antihistamininergic agents, right? Can help us to get through the difficult period. And then if the patients are there really for a long time and really anticipate anxiety, PTSD, we can definitely even consider starting, SSRIs, kind of thinking about the long-term prognosis and what's going to happen. So the last, again, this is based on the table in the article, right? Just kind of approach, right? So we inquire, right, and measure dyspnea by words, by asking questions and using the appropriate screening tools, right? Whenever we think about it, we'll, as CL psychiatrists, we can elucidate contributors to dyspnea, the medical condition, the ventilatory settings, right? Versus now also neuropsychiatric conditions, the anxiety that is overlaid, the delirium, the pain, providing the education and reassurance to patients and family and the teams, treating underlying conditions and comorbidities. This is, of course, on the ICU side, adjusting ventilatory settings as possible on the ICU side, but we can have a dialogue, suggesting some of the non-pharmacological interventions, considering using opiates for treatment of dyspnea. And then if they have comorbid anxiety, like we're kind of thinking about the agents with more immediate onset of action, moderate onset of action, and long onset of action. And if a patient has comorbid delirium, right, which is also not uncommon, dyspnea and delirium, right, probably not going to use benzos, right, but we can kind of, again, think about our agents, alpha-2 agonists, antipsychotics, anticonvulsants. And then again, talking, right, nurses, respiratory therapists, ICU physicians, and just having this increased multidisciplinary approach to the management, but hopefully also research of dyspnea as well. All right, so just some of the, additional references, but this third one, right, the dyspnea in acutely mechanically ventilated adult patients, this is kind of a statement from the European Society. I definitely recommend for everybody to read that paper and see what else we can do to support our patients. Thank you so much. And I'm going to stop sharing so that I can see everybody.
That's awesome. So thank you. That is a great summary of a lot of information. So we have a number of questions. So the first one is, as a CL psychologist, curious about non-pharmacologic interventions, if there's any evidence, particularly for like cognitive intervention, CBT, DBT, grounding, things like that.
I mean, excellent question. And obviously, yes, excellent question. I think there's some evidence that is emerging, but there is so much more that we can do to study and to do, right? Because of course, right, what I did not also mention is that there's, of course, right, the brain-lung connection, but there is the cognitive and the emotional overlay, right? Of course, our patients have feelings towards their experience and they have thoughts towards what's happening, and that matters, right? If the patient, let's say this patient, who does have this chronic dyspnea and things are optimized, but they're not feeling comfortable, and that makes sense, right? And the meaning that they prescribe to those thoughts, right? I'm dying, nobody pays attention to me, nobody cares, right? Versus this is very uncomfortable, but I can get through this. Of course it matters. So I can definitely see how CBT can be helpful, especially with the subset of these patients, right? Potentially hypnosis can be also helpful. I do think there's a big role for this and, and a place to grow, definitely.
Awesome. All right. And actually I think we've got more questions than we're going to be able to cover. So we'll try to do our best, but how about using O2 by nasal cannula, like a placebo effect for anxious patients, and subjectively feel less air hunger? Any thoughts about that, even when they're not hypoxic?
Yeah, I mean, there's sort of dangers, right? And the ICU physicians do not like using oxygen when it's not needed because there's also, that can be poisonous, right? And I mean, and it messes up with a normal respiratory drive. So that's not an appropriate intervention. I mean, I know sometimes maybe that's an easy thing to do, but if the patient is not hypoxic, that's not an appropriate intervention, right?
Yeah. We also have a question, and I can say, like, from a family experience, that what can we do for patients with a subjective feeling of throat tightening leading to anxiety? And did you see anything about that in Globus?
Yeah. So, I mean, that's I feel like that's going to be even a separate it's a separate whole discussion, right? But I do think it's more kind of tied to the chest tightness, right? So I'd really think about that mechanistically and definitely think about, separate pathophysiology leading to that and contributors, right? And the thoughts that arise. So I feel like that's a bit of a separate topic.
Absolutely. All right. Now we had a couple of questions about antipsychotics as well. So one about using IV Haldol and a role for IV Haldol versus, and then one about antipsychotics or during weaning, ventilator weaning. But
yeah, so usually kind of when we think about antipsychotic, right, again, this is where we're managing now, right, the comorbidities of dyspnea, right, anxiety, right, or delirium, right? So usually, I mean, I probably would use, Seroquel when I do use it because it's antihistaminic, right? Mostly because of its antihistaminic property versus dopamine blockade. Of course, if somebody is, has delirium, then probably Haldol, and we need more of that D2 blockade, makes more sense. I think sometimes, just in general, right? The ICU physicians feel like Haldol, it's more powerful, or the teams feel so desperate that they might use it, even if we do not recommend it. But I do think when we think about more dyspnea-associated anxiety, I probably, as the first step in antipsychotic, I would think about Seroquel because it's more antihistaminic. Probably not olanzapine as the first line because it's also so anticholinergic, and I do not want to worsen the delirium, right? We kind of have to think about all of those comorbidities. I mean, IV Haldol probably if everything else is not working, and definitely they have delirium.
All right, great. Now, one question about like sort of the subjective nature of dyspnea and sort of matching the different like sort of pathophysiology and treatment, but also personalities, and if there's any difference there, like interaction.
Absolutely. And I'm sure like my team is thinking about one particular patient that, we've been taking care of for a long time, right? All of that matters, right? The incoming pathophysiology, right? If somebody already comes in with anxiety, right? And personality factors and how they perceive the dyspnea, right? And the thoughts that they create to this and how they respond, right? It all becomes like one big mess, unfortunately, right? But we often do see patients. It is more difficult for patients who already struggle for control, right? Who already feel invalidated, right? And then they do have this, real physical thing that is happening to them, and the brain is screaming, "Oh my gosh, I cannot breathe," right? And in a way, it of course now validates what they thought, that nobody cares, right? And they're gonna die, right? So those patients likely will do even worse, and they're gonna have even, more challenging experience. So yes, all of that matters, right? And we do see in ICU that it becomes a very complex interplay of those factors.
Absolutely.
But then working with our psychology colleagues, if we have them in ICU, is even more important.
Awesome. Great. All right. Probably just a few more questions. So one is, how do you balance over sedation with CO2 levels and sort of balancing all of that? I think that's one of the really hard parts of working with the teams.
Absolutely, because of course if somebody's now hypercapnic, right, like, they likely at some point they will become sedated and drowsy, right? So it's a very gentle balance, right? That's what we often do with in ICU, right? We help them with anxiety, right, associated with dyspnea, so we can wean patients off. But and I'm sure everybody has struggled with that. But then if we do a bit too much, maybe now we oversedate them. Now they kind of maybe they're blaming us even, right? So it is a gentle balance. And in a way, when patient is intubated, right? I mean, I think in a way it's easier to do some of the interventions because we know that they're supported, right? When patients are even extubated, now they are breathing on their own. This is where we do have to be more gentle, more careful, right? We do want to help with the anxiety associated with dyspnea, but we have to be very not oversedate. So, and of course, if somebody's becoming hypercapnic, it might be the time that it is for us to step back now and really for the team to adjust that before we can intervene back. So I do want to acknowledge it's a very gentle balance.
Yeah, absolutely. There were a couple more questions about medications. One was, did you review anything or any experience with psychostimulants, maybe helping support with fatigue and tolerance?
That's a good question. We haven't specifically mentioned in the paper, but yes, there are definitely cases, right, where it's more common that the patient is so deconditioned, right, or they have also comorbid hypoactive delirium, right, and it's hard for them to stay awake, right, and then it might be that actually using psychostimulants might be helpful, right, because they're able to breathe better. So we're not covered in the paper, but it's definitely something that clinically we've done in a few cases, and definitely something to keep in mind.
Great, good. And then one other like clinical, any differences between like guanfacine and clonidine and different approaches that way?
Yeah, we do definitely use guanfacine a lot. We use guanfacine more these days than clonidine, right? Guanfacine is a more potent alpha-2 agonist, right? So it's actually more helpful, right? And it's not going to lower the blood pressure as much. Clonidine, of course, is available in the patch, so there's no enteric access, right? That might be helpful, but definitely our first approach, if we were to use something like Dex, right? because we definitely use guanfacine over clonidine because so much of in itself with, alpha agonist activity.
Great, good. Well, thank you. This is a great article, and also your clinical experience adding to it. So this is wonderful, and I really appreciate your time and all the questions in the audience. So.
Absolutely, and thank you everybody for joining. Really appreciate the enthusiasm.
Absolutely. Take care. Bye-bye.